First of all, to be honest with you, I'm afraid to my present in a simple case. After such spectacular cases which Dr. Franklin presented. So anything, but I have to do my duty. So I think that my present case is 14 years old in a paravalvular leak of the prosthetic tract valves after extracardiac Fontan operation for hypoplastic left heart syndromes. So I think it's why so problematic the paravalvular leak after the prosthetic valve replacement. Incidence is 1.5% of all prosthetic valve replacement. Issue is a heart failure or hemolysis, infective endocarditis. So treatment choice is a redo or interventions. But I think I need more specific imaging or care for the interventionist for PVL in normal heart. But even more difficult in congenital heart disease. Actually, very few report from the pediatric cardiology side. So I think that this case, a 14-year-old boy, and surgical history was a first node stage, and first stage operation was done in day 9, bidirectional grand tractive valve plasty, and at 4 months old, and also in 3 years old, he has done the extracardiac TCPC with tricuspid valve plasty again, but he developed in a tricuspid regurgitation significant amount, and then he had in a TVR. Using for the ATS in the size of the 24 millimeter at 14 years old. And also he had stent implantation for the left PA at 4 years old, and also left PA stent post-dilatation at 14 years after the TVR, which was compressed by the surgery. And now his status was NYHA in a class 2 to 3. And this is a check-ray shows right side before TVP and left side 1 month after TVP. I don't know why the cardiomegaly was progressed, but I think it's this is RVG. So right side before TVR, so significant in TR, and also the right side. This is for the after the TVR. So this is a prosthetic valves, and there is a significant amount of like a TR. And this is the echo shows again left side before TVR. And the right side after the TVR. I think you may see in a significant residual leak at the paravalvular leak. And even after TVR, his heart failure resumed also intense and anti-heart failure medical therapy, including pulmonary vasodilators. He had easy fatigue and restricted daily activities, could not go to the school, not like before in the surgery, and also pretibial edema. And morbidity he has is a liver fibrosis and cirrhosis with pancytopenia or mild esophageal varices and hearing impairment. And also hazard for the surgical redo TVR. So he has a dense adhesions and restrictive ventricular physiology and poor postoperative recovery from the previous TVR. I think it took about 14 years to dissect and like before the TVR done, and he's finished. His operation was finished almost on the dawn of the next day. So I think my surgeon was not to do this redo surgery for this patient especially. So our choice of treatment for PVL is the interventions. So I think it's a very important issue for this PVL, a paravalvular leak of the prosthetic valve is the imaging, and how to access and device directions and size directions, how to cross the whole of the paravalvular leak. So this is a 3D echo shows. So this is red one the tricuspid valves and blue one the aorta, and yellow one the PVR. So I think it's another 3D echo shows. This is for the PVR, just next to like tricuspid valves. And also yellow arrow shows in the hole of the paravalvular leak. And also this was elucidated by the color Doppler too. The size of the hole is 3.8 times 5.6 millimeters. Atrial side is diameter is 7, and ventral side is 7.4 millimeters. And how to access the regions? So one is transseptal approach, and another one is the retrograde approach. So I think it's a transseptal approach needs perforations by Nikkanen or broken brow, and also puncture sites of PTFT tube or in the PTFT to IVC junction. So, but could be feasible but difficult to do. And also retrograde approach. So wire cross and guide it's very important with how what kind of the guide wire to use, and wire choice and sheath choice. So we taken a retrograde approach. And so the device, what kind of device we use? So although you are thinking that in Japan is a far behind country for the pediatric devices, we only use for the several things. So I taken AVP2. And this is probably a leak assessment with 3D echo. And also measurement was done like this way. So we chose in AVP2 in a diameter of 8 millimeters because of like diameter of the 0.5 millimeter times 2.9 area is 0.11 square centimeters. So I think it's how to access the lesions. I think this is made by the 3D in a CD. And then this is a hole. We approximate to like a guide wire to cross by the guide cast like this way. So I use for like we call in a PV cast, which we usually use for this in a PV cast for the just in put in the measuring for like left atrial pressure and also PV pressure in the case with after the Fontan procedures. We usually routinely use for this cast for to measure for the LA and the PV at the time the Fontan patients. So I think the passing 0.35 in a thermal guide wire and also probably leak hole by the PV cast customized to cut in a 1/3 loop of the pigtail cast and extend PV cast to the 120 centimeters length in a 4 French multi-purpose cast and place 0.35 or 0.35 safari guide wire to XL1 just above the ATS and TV valves. Inside the place the 0.01 for the cruise guide wire in LA for the secure, and exchange in a 4 French multipurpose to the 5 French destination long sheaths into the LA. So like this way. I think it's we are very not difficult to pass through in the guide wire by this in a transorthotic approach. And device implement first implanted for the AVP2 in a size of 8 millimeters through the 5 French destination. But unfortunately, migrate then we need to retrieve the space devices. We just crossed again, and second implantation was made by the AVP in a size of up to like a 10 millimeters size, and through the 5 French destinations. This was successfully embolized, but I think the catalog of the AVP says I think that we definitely need for like a 6 French, but I think the destination long sheaths we can pass through in an AVP with size of 10 millimeters is a 5 French destination sheaths. So I think that we deliver introducing basket plug 8 millimeter through the destination, then change for the 10 millimeters, and device implantation. How to difficult to set up the appropriate position of the paravalvular devices along the prosthetic valves. I think with several back and forth, and to try to make sure like a color Doppler through in a hole was minimized. So then we decided to choose this in the right position in the right side, right panels. And this is a post and device closures RVG, so we don't have any much in the tricuspid urge at all. And this is for like a 3D echo after the device closure. The device doesn't interfere for the motion of the tricuspid valves. And this is for the small color Dopplers present on just only for like the ventricular site. And this is what TTE shows in device positions approximate to like prosthetic valves. So conclusion, I think the percutaneous embolization for paravalvular leak is feasible even in a case after the extracardiac Fontan for hypoplastic heart syndromes. So retrograde approach by a special design for the PV cast allow easy access to PVL lesions in case after Fontan procedures. So multimodality 3D imaging is of great help and essential not only to plan the treatment strategy, but also to monitor the procedure and evaluate its outcome in the PVL. So thank you very much for your attention.